You know about the mammograms. You know 1 in 8 women will be diagnosed with breast cancer. You know more women are surviving than ever before. But do you know what life will be like after breast cancer? Well, you will if you stay with us for this edition of It's Your Call. Hello everyone, it's good to have you with us. I'm Lynn Doyle. You know, for years I've been using this show as a forum to educate you, our viewers, about breast cancer, what you should be doing to prevent it, who's at risk to get it, what the warning signs are, and what the latest treatments are. Well, today I want to give you the opportunity to learn about life after breast cancer. You see, the good news is the odds of surviving are getting better all the time. But the bad news is getting a clean bill of health, so to speak, doesn't always mean the end of the ordeal. Here to tell us more about life after breast cancer, a longtime friend of the show and a personal favorite of mine, Dr. Beth Dupree. She's a board-certified surgeon specializing in breast care. She is now the medical director of the breast health program at Holy Redeemer Hospital, which is near Philadelphia. She's also a national speaker on breast health issues and the author of a book called A Healing Consciousness, A Doctor's Journey to Healing. Joining our discussion as well is Dr. William Scarlett, who is a board-certified plastic surgeon with Bucks County Aesthetic Center near Philadelphia, where the focus of his practice is breast reconstruction. And Kimberly Albright is here. She was diagnosed with breast cancer in August of 2010 at the ripe young age of 36. She's going to tell us what life has been like for her after her breast cancer diagnosis. I want to thank everyone for being with us, particularly you, Beth, given the hectic schedule that you lead every day. In the past, you and I have talked about what it means for a woman to get the diagnosis that she has breast cancer. What does it mean when you look at her and say, we got it all?
Well, the biggest part about breast cancer that people tend to underestimate is the aspect of what we call survivorship. And you can go through the breast cancer treatment, you can be told by your doctors, and you can understand that the cancer's gone and the chances of it coming back are highly unlikely. But if you are not able to get to a place where you wake up every morning and not have it be the first and last thing you think about every day, you're not surviving and you're certainly not thriving. And what we strive for in our practice is to get patients to a place where after a diagnosis of cancer, it's not the thing that they think about all the time, that they come through it and they learn from the cancer experience, and they actually are surviving and living every day to its fullest.
What kind of tools do you use to give them that confidence that they can in fact move forward with their lives and they don't always have to be marked by cancer?
Well, first of all, it's early detection, you know that.
Right.
The earlier we find a cancer, the least invasive procedures we have to do on our patients, such as chemo and surgery and radiation. But state-of-the-art care of the cancer is first and foremost. In addition to that, we provide our breast cancer support group. We have our Bucks County Breast Friends. You've met many of those.
Walked with them.
Walked with them.
Many miles.
We have a monthly support group, both the Bucks County Breast Friends and at the hospital Holy Redeemer, to support our patients. And creating those relationships with other people who are way far down the path before them. So when you see someone that's 10, 20 years down the road who's survived their cancer and thriving, it says a lot to someone who's young, who's still paralyzed with fear.
Are the majority of women paralyzed with fear because they think the cancer will come back and it's a physical fear, or is it more an emotional or mental scarring because of what's happened to their body and what they've been through, whether it be, you know, removal of the breast or reconstruction or chemo or radiation or a combination of all of those?
It's typically the emotional and the psychological stress of the fear of cancer returning. And none of us have a crystal ball to be able to identify at what point, you know, in our lives anything could happen. But releasing that fear and being able to have those tools to really heal. And this is the difference between curing cancer and healing cancer. And we've talked about that before, because someone can be cured of their cancer and be paralyzed and they don't heal. And that's why the things that we do with, you know, great reconstruction and self-awareness and self-esteem and helping our patients get back to a place where they feel good about themselves, just physically, emotionally, and psychologically.
All right, well, one of the ways that women do often feel better about themselves is if they've been able to have reconstruction. And I know, Dr. Scarlett, that this is the primary focus of your practice. Is it always as simple as, oh, I'll just go into the hospital, or immediately after I've had my cancer cured, I'll have a new set of breasts and life will go on and things will be perfect?
No, with reconstruction, often we're doing more than one surgery, and we need to prepare the patient for the fact that this may be a multi-step process, but certainly we want to be there at the beginning so that when they do wake up from having had their mastectomy, their reconstruction has been started.
You know, it's interesting because when you just said that it's often several steps to reconstruction. I was surprised the first time I did a show on reconstruction because I, like perhaps a lot of people, just assumed that when you removed the cancerous breast that at the same time you would just replace them, and it's not that easily done, is it?
Well, it depends on the patient and obviously their anatomy and what they're trying to accomplish. In some cases we are able to go right to an implant, but more often than not we need to start by putting in a tissue expander and slowly stretch that skin. So there is at least a second surgery when we go to put in the permanent implant.
Now you mentioned the tissue expander. I wanted you to bring us some photographs and also some examples of what you actually do to reconstruct a breast. Can you explain for us what we're looking at there?
70% of the reconstruction that we do in the United States is with using a tissue expander. And it's basically that skin has been removed during the mastectomy, and to achieve the desired size that the patient wants, we need to stretch the skin that's still there before we can put in a permanent implant. So as you can see, we're slowly stretching it each week in the office with salt water until we've stretched the skin to the size that we want it to be. And then it's a second outpatient surgery that we would then remove the tissue expander and put in the permanent implant.
Now, is this painful? Is this a painful process?
The stretching in the office isn't uncomfortable. It's the initial surgery with the mastectomy and the placement of it that we certainly need to be treating them in the hospital and for that first week at least afterwards with pain medication. But when we're in the office, we take advantage of the fact that the skin tends to be numb for about 6 months after the mastectomy. So when we're putting the needle in and stretching the skin, they don't tend to feel that.
Is it, can you describe for us, Beth, what it's like for a woman that first time that she looks at herself after she's had a mastectomy?
Well, it's usually with me, and I have some patients who are resistant to actually look at their incisions, and I encourage them to look while we're in the hospital because I don't want the first time that they take a look under their bandages to be at home when they're alone. And for the patient who's undergone reconstruction, usually I see them, their eyes perk up a little bit because I think they're expecting to see nothing or a large kind of disfiguring scar, and they see some little steri strips, and particularly if the patient had enough skin, they actually see what looks like the beginning of their breast mound being replaced. And for patients who don't undergo reconstruction, there's definitely a different feel, and I've tried to prepare them by showing them a picture of what the final result's going to be because it's an incision flat against the chest wall. So there's a marked difference in what they see. And the patient that undergoes immediate reconstruction, there's definitely a psychological benefit, I think, immediately post-operatively because that part of healing and reconstruction is beginning together at the same time.
But you mentioned that not all women are candidates for immediate reconstruction. Sometimes there has to be a period of time that they have to live with the lack of breast, the loss of their breast, and that must be very difficult.
It is difficult, and that tends to be the inflammatory breast cancer, and we tend to wait 2 years from the time of the initial mastectomy until we would do the reconstruction, but fortunately that's a very small percentage of breast cancer that's diagnosed.
Yeah, because 2 years for someone sounds like a lifetime. I'm sure they're probably trying to keep it in perspective that they're alive and they have those 2 years, but it's a long time when you're a woman to live without what defines you as a woman in many cases. So depending on the type of breast cancer, that depends on when you can have the reconstruction. Now you mentioned that there are different types of implants that you can use when reconstructing. Can you explain that for us?
Certainly. We've had silicone and saline implants for a number of years. Obviously in 1994 the FDA took off what we call the liquid silicone implant. But 5 years ago they re-released the gel silicone implant, and the difference being that it can't leak. The concern that we had before was that it was a liquid silicone, it could leak, but now with the gel silicone implant